Thank you for the opportunity to speak to you today in support of the Title VII and VIII Geriatric Health Professional Programs on the 50th anniversary of these programs. During this session, we hope to expand your knowledge of the Title VII and Title VIII programs. You'll understand that they're the only federally funded programs to build a geriatric health professions workforce to meet what are the urgent needs of our nation's rapidly aging population. And we're hopeful, pretty confident, that as you learn more about them, how they're essential in order to fill this critical workforce shortage, and how they continually evolve and adapt to meet the changing needs, you'll fully support their continuation. So to begin, I'd like to briefly tell you a little something about myself so that you can place my comments in context. I'm a geriatrician. That's a physician with specialized training in the care of older adults, and I come from the University of Arizona, which is in Tucson, Arizona, where I'm a professor of both medicine and nursing. I've been in practice in Tucson as a geriatric clinician, educator, and researcher for over 25 years, despite my continued Brooklyn accent. So how did I come to be a geriatrician? I've always been drawn to provide care for the disenfranchised. And during my medical training, my decision to care for older adults really crystallized at that time. I hold deep respect for older adults, as I'm sure all of you here do. And I value their wisdom and their resilience, and I also understand just how challenging it can be to grow old in our society. In my medical training, the unmet needs of frail older adults were really overwhelming and undeniable. And so I chose to train and become a geriatrician in the early 1980s, when ironically it was still a kind of young field. It makes sense. As a society, we were just beginning to be confronted with a rapidly growing and aging population, and just beginning to understand the unique healthcare needs of older adults. And that's kind of a wow slide of a rapidly aging population, especially those over 85. One of my first positions was as medical director of the VA home-based primary care program in Tucson, which some of you may have heard about, providing primary care at home to veterans with advancing chronic conditions. And I remained as director for over 25 years. Primary care in the home for frail elders, now that's an innovative concept. My practice was house calls as a member of an interprofessional team. And I remember sharing the story of an 87-year-old veteran who was referred to our program. He had advanced heart and lung disease, and 6 months before we met him, he had suffered a stroke and had weakness on his left side. His 82-year-old wife was struggling to care for him in their home, but they had promised to each other that they would try to remain at home together for as long as they could. Over the past year, he had been in and out and in and out and in and out of emergency rooms and hospitals for exacerbations of his heart failure and for recurrent pneumonias. And they were, when we met them, they were confused about his medication. He was losing weight, he was depressed. Physically, it was hard to take care of him, and they were both scared about what the next day would bring. Our geriatric trained team, our physician, nurse, pharmacist, social worker, therapist, dietitian, psychologist, all work with them to stabilize his medical conditions, and we were available for urgent and emergent problems. The trained team, was able to anticipate and prevent complications that are unique to the frail elderly and predictable in the frail elderly, such as falls and delirium. And we helped them to identify their goals of care, what they would like to see happen, and their values. And he spent the following 9 months at home with us with no emergency room visits or hospital visits. And he and his wife really enjoyed the highest quality of life possible. And importantly, this was also at much lower cost than usual care. It didn't take long for me to recognize that it takes a skilled geriatric interprofessional team to provide the highest value care, and that would mean best outcomes at lower costs, especially for older complex patients. I also quickly saw the incredible problems that are encountered when a skilled geriatric team is not available, when health professionals are not prepared to care for complex older adults. So high-quality, cost-effective care requires a skilled and prepared team. This is exactly what the health professions educational programs do. They build that prepared geriatric workforce. But let's talk about it a little more, because it forms the basis for kind of understanding both the current workforce crisis and the heart and soul of these programs. So, on that slide, as a geriatrician, I am actually a rarity among physicians. There are only 7,300 of us in the United States, one for every 2,500 Americans over the age of 75. As you know, the first baby boomers began to turn 65 this past year, and within 20 years, 1 in 5 Americans will be over 65 years old. This slide shows a distribution of geriatricians, and red is bad, but green, even green isn't very good if you look at the ratios there. Due to this projected increase in the number of older Americans over the next 20 years or so, the ratio of geriatricians to 75-year-olds is expected to drop even further to 1 for every 3,800 older Americans. By then, it's estimated, these are conservative estimates, that we'll need 30,000 geriatricians just to care for what will be over 20 million Americans, older Americans, and the numbers are staggering. There's also a dire shortage of geriatric healthcare professionals across all the disciplines, and I can list them: psychiatrists, psychologists, physician assistants, and so on. I won't go through all of them, but include direct care workers. But why is the lack of geriatricians and other geriatric health professionals such an urgent national problem? Why do we need geriatricians or geriatrics at all? Well, I keep saying that older, frail adults need to be cared for by a healthcare professional who is prepared and trained in geriatrics. But even some of my colleagues needed convincing of this concept, and so I'm going to kind of take you through it. I would suggest that all of you in this room would agree that children are really very different from adults, right? That their health care needs are quite different, their emotional status is very different, and all of you would readily accept that we need specially trained physicians, in this case pediatricians, and special models of care like children's emergency rooms to provide high-value care for babies and children. Readily acceptable. Well, it's the same for the older adults. When we think about people who are 75 and 80 years old, a 75, 80-year-old is as different from a 40-year-old as a 7-year-old is different from a 40-year-old. Different physiology, different illnesses, different conditions, often multiple coexisting conditions and multiple medications, different ways they present with their illness, different responses to the medications, different goals of care, and on and on. This rapidly growing older group also costs a lot of money in healthcare. We know that older adults use more healthcare. 90% of people over the age of 65 have one or more chronic condition. And we know that when we look at the Medicare population, it's 20% of the Medicare population, those with 4 or more chronic conditions, that cost 80% of the total Medicare healthcare dollars. And despite these high costs, the quality of care and the satisfaction is certainly not optimal. Skilled geriatric health professionals provide higher quality care at low costs, higher value. A physician, nurse, or other healthcare professional who has just received usual training in adult care is not prepared to care for an older adult, any more than they would be prepared to care for a sick child. So we need people trained in geriatric care. For that, you need the teachers, you need the faculty in order to train. Now, in my roles at the University of Arizona and nationally, I'm really privileged to be closely involved with the Title VII and Title VIII programs. I can confirm how much the older adults and their families in our community, in our state, and nationally have benefited. And as I said, I equally know the problems that the critical shortage of geriatric healthcare professionals yield. And with our rapidly aging population, market forces, that's widened the gap between supply and demand, and the task is daunting. I have to mention that the instability of continued federal funding from year to year also creates unnecessary chaos and angst for program faculty, students, patients, and families. But of course, we can't slow down and we can't give up. And that's why I'm pleased to speak to you today. And now I'm going to briefly review the programs, highlight why they are so important to older adults, and give you an idea, a small idea about how they work within the University of Arizona. As we go through them, I'm leaving out a lot of details, so please refer to your handouts for the specifics. So let's first talk about the Geriatric Academic Career Award, affectionately known as the GACA, and why it's an important program. The GACA program promotes the development of academic clinical educators in geriatrics. These awards are given to specific junior faculty in an academic institution and provide the really much needed support to build their career as a teacher and a clinician. And as a result, to ultimately build the academic capacity to expand our workforce. In 2011, the GACA program trained 66 full-time junior faculty. These are passionate and energetic clinical educators. These awardees are readily recognized within their institutions as truly exceptional people, and they fulfill the promise of the award. And although it seems obvious, it's worth saying we need the GACA in order to fill gaps not filled by market forces and to train our healthcare workforce. At the UA, at the University of Arizona, I've been privileged to mentor two GACA awardees, Dr. Janet Campion and Rosemary Brown. They're extraordinary faculty leaders at our institution, training medical students, residents, fellows, and faculty, clearly show what this award was meant to yield. Not only do we need to sustain the program, we would recommend an expanded program with a more frequent award cycle. Right now, it's only once every 5 years. You can see how that's really too episodic in many ways in order to yield the best results. And I'd like to talk about geriatric education centers, or GECs. They provide quality interprofessional geriatric education and training to practicing healthcare professionals of multiple disciplines and students. And in every state where there is one, they are the go-to resource for geriatric education. In 2011, 45 GEC grantees developed and provided an astounding number of trainees, continuing education, and so on, significantly exceeding the program's performance target. As of note, 3/4 of these trainings are interprofessional, right? And overwhelmingly, they were in medically underserved community or health professional shortage areas. Our GEC is the hub of geriatric education activity in the state, and in our consortium includes the VA, includes our rival Arizona State University, schools of nursing and social work, and I mention that only to show how these funds really, in almost every state, geriatrics plays together, and we leverage resources. We closely collaborate with multiple partners, including the Indian Health Service and our area agency on aging, and again, to affect the greatest number of people with these limited resources. We foster interprofessional geriatric clinics throughout the state. We teach health professional students about geriatrics in the classroom, in the clinics, in the home, and in the hospital. We work as a member of a national GEC consortium where all the GECs together working to reduce delirium, which is just a critically devastating problem that occurs in older adults who are hospitalized. And lastly, in order to break down stereotypes that students often have about aging and end of life, we bring together health professional students from nursing, medicine, pharmacy, social work, and even basic researchers with healthy, active, vibrant seniors in our community as part of our very successful interprofessional senior mentors program. It's very effective in dispelling the idea that all seniors are frail or suffer from dementia. It really helps mitigate ageism, which sort of threads throughout this, and helps build an interprofessional pipeline of geriatric health professionals. Next, I want to talk about geriatric training program that's listed up there. This program supports the training in medicine, dentistry, behavioral health, and mental health. The program has been very, very successful. In academic year 2011, a total of 63 fellows, psychiatrists, dentists, and psychologists were supported through this program. And again, it creates a critical pipeline. Lack of dental health is often listed in a community's as a community's primary need on health surveys that are done, especially community benefits surveys from hospitals. And this was the case for Tucson last year for several years. Most older adults, many older adults, don't recognize the need for ongoing dental care and often have to be encouraged to seek it. Poor oral health is associated with malnutrition, social isolation, depression, and many severe dental problems can really be managed by a skilled dentist and taking away a medication as simple as an allergy pill or an antihistamine that might be drying them out. But even if they seek the care, it's hard to find a dentist who will provide it, especially in rural areas. Most dentists aren't trained in geriatric dentistry and are often very hesitant to treat the frail elderly, especially, and think about it, if they have physical disabilities that make it difficult for them to even get up into the chair, or heart or lung problems that may seem really overwhelming to an unprepared dentist. And regarding behavioral and mental health, well, we all know that older adults can suffer from depression, anxiety, delirium, dementia, caregiver burdens, and bereavement. And geriatric trained psychologists and psychiatrists are an incredibly important part of our healthcare team. A geriatric skilled behavioral health provider can make a difference between someone with dementia and associated behavioral health problems being able to stay at home versus being institutionalized for the rest of their lives. The last program to talk about are the comprehensive geriatric education programs. And this is a new and also a very highly successful program that focuses on quality geriatric education for individuals who are caring for the elderly, including direct care workers, and supports training for nurses who care for the elderly, training of faculty in geriatrics, and continuing education for nurses practicing in geriatrics. It's recently been expanded to advanced practice nurses, and there were, in 2011, 18 comprehensive GEPs, and they provided an overwhelming number of services and instruction. And again, in Arizona, our Arizona State University was awarded a CGEP, and we at the University of Arizona's GEC work collaboratively with them to leverage resources and expand trainings. And this is repeated. This is not just Arizona. This kind of collaboration across the country. So in conclusion, the aging of America really demands a well-trained workforce. Over 10,000 people turn 65 every day, and each one deserves to be cared for by a health professional who is trained in geriatrics. The Title VII Geriatrics Health Professional Programs, as I said, are the only federal programs that seek to increase the number of faculty with geriatrics expertise in a broad variety of disciplines. And it's clear that today's healthcare workforce is inadequate to meet these needs. Each week, I receive calls from people within the state or from families all over the United States who are seeking a geriatrician to care for their loved one. Sometimes it's a wife or husband, sometimes it's a son or daughter whose parents are moving to the state. And it's the hardest calls to yield because, although I try to connect them with the geriatrician, often it's impossible. And this is repeated every day throughout the country. This is not just an Arizona issue. Title VII and VIII are critically important programs that expand the geriatric health profession workforce and have continually evolved and adapted to meet our changing needs. They work together across programs, share resources, collaborate and build education and training networks across the country. And I think it's clear we have an obligation as a society to provide this quality care that our elders deserve. And this high-value care, remember, it's cost-effective. So I want you to know we have a track record of highly successful programs, but there's still a lot of work to do.